So, friends, it's my pleasure to introduce two very distinguished speakers amongst us. We have listened to them before. Not to Dr. Sanjay Choudhary. He is going to talk on stroke factors. How do you manage stroke? And what about this? How do you modify stroke factors as well? And can I give a little brief introduction? He was formerly at Patra Hospital, the HOD of Patra Hospital, and then he shifted now here to IBS, and he's HOD here. And he's going to talk about the stroke risk factors management, but I would request him probably to donate some time on Alzheimer's, because today is Alzheimer's Day, friends, and probably a little on Parkinson's as well, and we love to listen to him. And the second speaker would be Dr. Vikas Gupta, who was at Mac Saket, then at Gurgaon as well, Maharaja Agar Sain at Punjabi Bagh, and now he is in this IBS hospital, and he's going to talk on personalized brain mapping and the future of neurological surgeries and treatment. So wonderful. We have an academic feast today. So friends, let's get started with Dr. Sanjay Choudhary. Sir, please, all yours.
लाइट बंद कर दो सर, लाइट बंद कर दो।
I forgot to introduce Dr. Kandari, who is the brain behind the IBS and the owner and all in all of IBS.
Also the
Thank
spine.
you, sir.
Also the spine, brain and spine.
Thank you.
Hello.
Thank you, Dr. Tulsi. Thank you all the esteemed members and colleagues. Hello. Yes, this is very good sounding. Thank you, Dr. Tulsi. Thank you all the attendees, our colleagues, friends, and my co-speaker, Dr. Vikas and Dr. Sachin. Today I am going to speak about stroke, the risk factors, and how we can manage them best. To begin with the plan of this brief talk, I will try to accommodate your points, sir. Today being Alzheimer's disease, maybe I will try to speak after our talks are finished, a couple of slides, yes. And also, if possible, about Parkinson's. I have the slides ready, but I think the time will not permit because we have back to back. And I want my core topic to be well discussed and well understood as well. Because as we understand, we have a new stroke plan also. So to begin with, my main aim is to introduce the topic of stroke, highlight mainly the ischemic stroke. I will leave the hemorrhagic stroke management not for today, but I will briefly touch on it. I will mention the statistics which we have internationally and nationally also, and how best and why should we treat acute stroke on a war footing. Then how do we evaluate for the risk factors? What are the common risk factors? What are modifiable, what are not? On top of that, I will especially take my main aim on management of all the risk factors. Especially I will highlight on two main risk factors, the atrial fibrillation management and management of capillary stenosis. And for the last. After that, I will make a small conclusion. Presume I will take about 20 to 30 minutes depending upon. If there are any questions, you can free to interrupt me in between also.
We'll ask the question at the end of your talk, both
Okay,
talks.
then that will be great. Thank you, sir. So, to begin with, stroke, it is a catastrophic neurological disorder. It disrupts the blood flow to the brain either by blockage of the arteries within the brain or by causing bleeding in the brain by a hemorrhagic stroke. As we see, the ischemia can result in a ischemic core, which is the umbra, surrounded by a penumbra, and that needs immediate management because ischemic stroke is the most commonest form of stroke. About 85% of all strokes are ischemic in nature, 15% only are hemorrhage. We need emergency war-footing management of stroke because time is break. And in fact, it is said that with each passing minute of a stroke being unrecognized or ignored, we have about 1.9 million neurons lost, with attending 14 billion synapses lost, and a total of myelinated fibers which can, if arranged line by line, up to 12 kilometers, and can cause, every minute can cause 3.1 V of loss of accelerated aging. So they lose that much of age. So you can calculate that. So per minute, you can calculate what will be per hour, what will be per stroke. So to begin with, what happens is, as soon as there is a ischemic infarct, there is a lot of excitotoxicity around this umbra and penumbra. There is a peri-infarct depolarization, and then there is inflammation which sets in. This inflammation can last for hours, and finally there is apoptosis with cell death within days. So this is to add to the simile that time is brain. It has come from time is money, then time is art, and now the time is brain. So we have to fight for each passing minute that we lose is going to be dangerous for the brain and for the brain recovery. So to summarize what is happening around the world, as we speak, almost we have about 14 million strokes every year, of which 116 million healthy years of life is lost because of stroke every year. This is the international figures, of which 80 million people are already suffering from the impact of stroke as we speak, leading to 5.5 million deaths per stroke every year, which means that almost 1 in 4 people who are 25 years and above will have the stripe of stroke in their lifetime. But the wonderful and the most important point which I am going to highlight in the rest of my talk is that 90% of all of these strokes, they are linked to 10 modifiable risk factors. So once we have had a stroke, not that you will never have a stroke again. You can have a stroke again. We'll come to the statistics again after a few next slides. 90% of the next stroke can be prevented if we can take care of these 10 modifiable risk factors, which I'm going to highlight in a short while from now. Now, coming back to the Indian scenario, stroke is the 4th leading cause of death and 5th leading cause of disability in India. There is a high prevalence of stroke in Indian population as compared to the Western world. Western world has learned to correct these risk factors. So the ischemic stroke ratio is getting down. But in India, we are on the rise. And they are saying that we have 1 in 5 risk for women and 1 in 6 risk for men on high risk of stroke, especially after the age of 55 years. It is said that the stroke causes more death in the country than the malaria, tuberculosis and HIV combined. As to be more specific, according to the Indian Stroke Association meeting, the incidence of stroke has risen by almost 100%, doubled in the past decade. An estimate 1.8 million suffer from stroke in India every year. Stroke attributes to about 30% of the overall morbidity in India. 1 Indian suffers a stroke every 20 seconds, that is 3 per minute, which comes to around roughly 100 to 120 incidence of stroke per 1 lakh population. The stroke risk in India is 1 in 5 in a lifetime. So every 5 of us will have a stroke in our lifetime. So we have a very big problem, but we have very small awareness. And this is our main aim of highlighting what is the stroke. Now, not every stroke which happens And similarly, about 15% of those who have had stroke, they die shortly after stroke. 10% of the stroke, they are survivors completely. So 25% either a complete recoverers or they are not there in the world. So the remaining 75%, they suffer from the stroke sequelae for the rest of their lives. 25% recover with minor impairments. So they move around as almost normal persons. But 40% experience moderate to severe impairments which require very special care. But the next 10%, this is the one in which they require care which either is skill care, so either they need hospital care or a nursing home care or a care at home with 24/7 nursing aids and ventilator assistance and tracheostomy. So that is a very poor quality of care. So our main aim of treatment in acute stroke is first to diagnose the stroke as early as possible, treat it as early as possible, and after the treatment, then we prevent their deterioration and improve the quality of life. So stroke rehabilitation, that is one of the big buzzwords in management of stroke. So why stroke prevention is important? So stroke prevention, as I have stressed, is one of the most catastrophic and lethal disorders you may have. Now, once we have had a stroke, doesn't mean no, now the worst is over. You are at a peril of another stroke. So there is a recurrence or the sequelae, the stroke returns, that occurs up to 10% in the first year. So suppose I had a stroke this year. In 23, I am going to have a 10% risk of having a repeat stroke within 1 year. Thereafter, the risk somehow lessens because we are more wiser and we try to control our risk factors, but still it is 4% after every subsequent year till the end of life. Next, now come to the topic of TIA. TIA, they are very minor, just a slurring of speech, just some visual aura, just some weakness. I recovered in 20 minutes. We are very happy. But within a span of next 3 months, there is a 10% chance. What is there in stroke for up to 1 year? That recurrence happens within a span of 3 months. And it is said the maximal risk of a repeated stroke happens within next 48 hours. So every TIA also has to be treated like a stroke. You should not try to trivialize it. Oh, it is a minor stroke. No, it is a stroke. This is what I would like to drive my point. There are some common misperceptions about the stroke. Commonly it is believed, oh, stroke, it is not preventable. But it is said that 80% of strokes, they are preventable. They say, stroke, oh, it cannot be treated. In fact, stroke is one disorder which warrants and needs emergency treatment. In fact, we should, that's what our next part of our talk will be, that we want people to reach us so that we can help them within a span of 3, maximum 4.5 hours to give them maximum benefit. Obviously, whenever you wake up, it's never late. So even you can come up after 6 hours or 8 hours or 24 hours, we have a protocol for that. But maximum help which we can give to our patients of stroke is within the golden period of 3 to 4.5 hours, where we can manage it easily with minimum of cost, investment and care required. Especially even in a ward setting, we can manage acute stroke after ICU care and stroke care, we can shift the patient to the ward. Whereas if the patient needs further more detailed interventions, we might have to keep in ICU for long. So earliest we recognize it, earliest we refer the patients to us and we treat them in time, the recovery and the management becomes easier for us. Usually stroke is misconceived to be coming from a heart. Because in a myocardial infarction or heart attack, usually the pain is localized only in the chest. So everyone knows this is heart. But when there is a stroke or a brain attack, it is never in the head alone. There may be headache, there may be loss of concentration when everyone knows. But sometimes and most often the effect is away from the brain point. It can be a loss of vision, it can be weakness in the hands, it can be numbness in the legs, it can be only a gait ataxia. So it can be distant and remote from the brain. So usually people think that it is only coming from the heart, what has gone from the brain. But it's a fact that stroke is a brain attack, it should be treated on a broad footing, and it is understood that stroke recovery ends after 6 months. 6 months में नहीं हुआ तो नहीं हुआ. This is a misconception. In fact, the stroke recovery can last till lifetime. This we have seen, especially with our neurorehabilitative tools. We have seen patients and make them improve even after years of old stroke. So it is a continuous process aided by brain neuroplasticity. With this, I would like to come to next. How we evaluate a patient of stroke. Whenever a patient of stroke comes, or a PIA comes, what are the factors we should go into? I must tell you, nothing can replace good clinical judgment. 80 to 90%, especially in neurologic cases, we are able to diagnose by a proper detailed history, detailed examination, but for proper help, proper evaluation, we need further routine investigations and specialized investigations. I will not go deep into this because we all know, we are all clinicians. So we must know the age, the sex, the symptoms, the past history is very important. The personal history, the addictions, alcohol, drugs and all. Diet history, what is the main constituent of the diet? What is the occupational history? What is the family history of stroke? Where is the social history? The detailed examination, we must check the height, weight, the waist, hip ratio, vitals, general examination, systemic examination, especially the neurological examination to look for the damage done by this stroke and look for its evaluation and progression. And then we come to the special investigations, like we can go for a CT scan alone in emergency, or we have to go for MRI plain with contrast if need be. Sometimes we have to go for CT angiography or MR angiography. Sometimes we have to go for such super specialized runs of diffusion, perfusion and diffusion-perfusion mismatch. Sometimes we have to do DSA for the brain and the neck vessels. And last, sometimes we have, especially in those with the family history, we might have to go in for a genetic study. So we must understand what are the blood flow to the brain. As we all know, the blood flow to the brain occurs from carotid arteries. There is an anterocerebral artery, midcerebral artery, and posterior artery which comes from the vertebra. And the both sides of the blood vessels are well connected by the circle of Willis, so that helps the collateral circulation whenever there is occlusion of one of the major arteries. Now, just evaluation of brain arteries are not enough because they are fed by the heart. So we must have a proper cardiac evaluation along with the evaluation of stroke. We must look at the atria. We must look at the atrial fibrillation existence, and we must hunt rather look for atrial fibrillation because they can be paroxysmal, so they can come and go. And while they come, they can make a clot dislodge and cardioembolic stroke can happen. Then we have to look for valve disorders. That can be done by echocardiography. We have to look for LA and LV clot. We have to look for the aortic arch plaques. We have to look for carotid plaques, pathogenic emboli which can come from the carotid arteries. And also we have to look at the intracranial atherosclerosis because sometimes it can be more distal small arteries which are occluded by either a cardiac emboli or an artery to artery emboli. We'll cover these details in the next. Also, we need a further detailed vascular imaging, especially about the carotid intimal pedial thickness. And sometimes we have to go for cerebral angiography to look at the stenosis. There are multiple ways of estimating the lumen of the internal carotid arteries. So now we come to how do we classify How do we classify the stroke? The stroke classification, as I have already told, they can be ischemic, 85%, 15% is hemorrhagic. Of the ischemic, 85%, there is a atherosclerotic cerebrovascular disease, which is the carotid and the intracranial main thrombotic disease, what we say, in 20% cases only. And another 25% is small vessel disease. Sometimes large vessel occlusion like carotid, vertebral, they may not be occluded, but they can be small terminal arterioles which can get blocked, which result in small vessel disease. We call them lacunar infarcts.
Probably we'll have more questions if you can finish.
Yes. And sometimes we have cardiac embolism, 20%, cryptogenic and 30%. And among the other causes are the dissection, vasculitis and genetic disorders. I will skip the slides.
Yeah.
So these are the detailed risk factors for ischemic stroke. So age more than 65, race, especially in blacks and in Asians, it is more. Women are more, especially because they have a pregnancy, they are on OCPs, so especially, and they have a larger lifespan as compared to men. And previous stroke or TIA, family history of stroke, migraine with aura and genetics are there. Modifiable risk factors include hypertension, coronary artery disease, carotid disease, peripheral vascular disease, rheumatic heart disease, atrial fibrillation, diabetes, vestibular, high risk of stroke, atrial fibrillation. It is a risk factor for cardioembolic stroke. And there is hyperlipidemia. In fact, the risk factor of atherosclerosis of extracranial and intracranial blood vessel is because of lipid. Total cholesterol increases the risk of ischemic stroke. Total cholesterol is inversely proportional to the hemorrhagic stroke. And raised HDL activity reduces the risk of stroke. Statin reduces the total and ischemic stroke risk. However, statins, if given in those patients who have previous hemorrhage, small vessel disease and cerebral amyloid angiopathy, they have an increase of hemorrhagic stroke. Sedentary habits and obesity and metabolic syndrome, they also are important risk factors of stroke. Ethanol has a J-sept curve, so 1 or 2 drinks is okay, but more than that increases the risk of both ischemic and hemorrhagic stroke. Especially addiction with cocaine, heroin, amphetamines and ecstasy, they increase stroke. Active smoking doubles the stroke risk. And even passive smoking increases the stroke risk by 30%. I will skip this slide. Inflammation and infection, they are not risk factors, but they are triggers. Now, stroke therapy overview. Most important thing is prevention of stroke. There is primordial prevention in which we take care of all types of prevention in a general population. Then we go to primary prevention, in which we modify the risk factors, and secondary prevention, we go for more aggressive management of the risk factors. The important risk factors are lifestyle modification and risk factor management. Apart from this, we come to the acute and chronic stroke therapy. So, stroke prevention, I have already mentioned, we have to go for non-pharmacological intervention like lifestyle modification, like cessation of smoking and drinking, exercise and weight reduction, and pharmacological intervention like control of blood pressure, sugar, cholesterol and cardiac diseases, and control of atrial fibrillation. The neuroradiological and cardiac interventions can include carotid and vertebral artery and vascular stenting, Watchman device for left atrial appendage closure in the patient of atrial who are adequately referred to and selected. Surgical interventions like carotid endarterectomy, which reduces 50% relative risk reduction and 13% of actual risk reduction in 2 years. So I have come to these modifiable risk factors. There are some factors which can only doctors modify. Some are to be modified by the patient. Regarding the antithrombotic therapies, we know all the antiplatelets. There is a combination, single antiplatelet, dual antiplatelet. I will not go into the details. We all know them. Oral anticoagulants, atrial fibrillation, as I said, I would like to highlight, because atrial fibrillation has a nearly 5-fold increase in the risk of stroke. So we want to screen for atrial fibrillation in patients who are more than 65 years old, in those who have obstructive sleep apnea, and those who are hypertension patients, at the age of 65, and those in more than 75, we should screen for all patients with high risk of stroke. So we are more worried about the paroxysmal atrial fibrillation. Stroke is more likely to be fatal in a patient of atrial fibrillation. So we have to assess what is the chances of their bleeding status by doing a CHADVAS and Hasbulat score. And commonly for atrial fibrillation, we have the option of either going for warfarin or aceclomurol. Otherwise, there are NOACs like dabigatran, rivaroxaban and apixaban. There have been a lot of studies of which we usually recommend either dabigatran or apixaban. So, to prevention of atherosclerotic stroke, mainly the extracranial, we can go for either a stenting or a carotid endarterectomy, which is better than medical management. Whereas for asymptomatic as well as symptomatic intracranial, still we have to go for medical management alone. Aggressive medical therapy is superior to intervention and stenting. So to conclude, tremendous strides in understanding risk factor of stroke and stroke prevention. Stroke risk factor study has revealed there is a heterogeneous etiology. There is genetics, there is environmental, and there is acquired behavioral risk factors. They lead to whether the stroke is ischemic or hemorrhagic. The same factor can cause ischemic as well as a hemorrhagic stroke. Lipids are risk factor for atherosclerotic stroke. Atrial fibrillation and atrial cardiomyopathy can cause cardiac embolic stroke. Genetic imbalances study, they have helped us, but still we are far away because they only account for only 1% of all cases of stroke. Medical and behavioral treatment for blood pressure reduction, statin therapy, antiplatelets, anticoagulants, carotid vascularization therapy, and dietary changes. They have proven to reduce the risk factors in various patient populations. With this, I would like to thank you for a very pleasant.
Well, we'll have Dr. Vikas Gupta going to talk about personalized brain mapping and the future of neurological surgeries and treatment. Dr. Vikas Gupta, sir.
Good evening, ladies and gentlemen. So I am here to present. I have been asked by Dr. Tulsi to be, slightly concise. I'll try to be concise and crisp. So I'm just going to talk about personalized brain mapping. According to us neurosurgeons, this is a revolution in present era, and that we understand is the future of neurological surgeries and other treatments. I'll just come to that. So number one, as a neurosurgeon, there is a dilemma. When there is a tumor and we operate, there is always a dilemma for surgical corridor, from where to enter, how to enter, what area to cut through. All these are very basic questions for a neurosurgeon, and we have been trained and we always think about it before entering into the brain, that is this area really important. So the questions which arise, I have just submitted. What is the suitable surgical approach to a brain tumor? Depending on the location, frontal, temporal, parietal, which is the area we should resect to reach to the tumor. The second question is how to avoid damaging an eloquent area. Now I have marked this eloquent in apostrophes because I'll tell you what is eloquent and what is not eloquent. But yes, eloquent area which is important for daily life, right? We have to avoid that when we operate. A good outcome post-surgery. Every surgeon just dreams that I operate on the brain and patient should be fine the next day. That is the biggest success and the worry for the doctor. Is the resected area of functional importance? Suppose we enter into the brain, we think, okay, fine, this area is fine. We can go through this area and reach the tumor and take it out. But we don't know. Is the resected area of functional significance? We are really not sure, sometimes. Then, neurosurgery has actually evolved quite a lot in last 2 to 3 decades. We have developed many neurosurgical tools for safer tumor resections. You must be knowing about that. I myself had worked in Max Saket, and I was actually sort of unofficial in charge of Brain Suite, which was the first Brain Suite to be installed in Asia for navigation and intraoperative MRI. I've used that, and I know still it had limitations. So neuronavigation is a term which I think everybody must be aware of. It is basically a system which tells you during surgery where is the tumor, where is the area we want to resect. It actually helps in localization of the tumor, but it does not give you any functional information that you are going through what area, what function does it carry. No, we don't know. We know that this is the tumor, and if we go through this path, we will reach the tumor. That is the importance of navigation. Second option is functional MRI, that also helps a lot. Functional MRI is a technique developed in Japan, and the doctor actually received Nobel Prize for that. And it just tells you what area, to some extent, is responsible for what function. We use it. We use it for mainly speech and motor function. But let me tell you, it has observer bias. A technician, a doctor who is doing it, he marks the area based on the activity shown on MRI when he asks the person to do certain activity. It's an observer bias thing. It gives you a crude area information. That this is the area for speech, let's say, this is the area for right hand movement, this is the area for right leg movement. But there is no track visualization. We don't know from where this information is reaching and what wires or tracks are bringing this information. We don't know about it. The other recent fashionable term is tractography, which is a recent development. It shows you the fibers. There are special sequences like DTI, diffusion tension imaging, which show you the special tracks. Like brain, we know there are tracks which are coming from cortex going down. We are able to see the tracks in a colored formation. But it only tells you these are afferent fibers going away from parietes to brain, and these are the efferent fibers like that with a color coding. But we don't know what is the functional element of those fibers. We don't know about it. Those are limitations we are still facing today. Then there is another thing you must have heard about. A lot of people are always saying awake craniotomy. It's a big fashionable statement. A patient playing piano while he is being operated on the brain tumor. People must be knowing that. So awake craniotomy is an important tool to preserve the function, that we go inside the brain, we take out the tumor, and we ask the person to perform a function during the surgery while he is awake. So that we know that this area is not damaged. Okay, fine. We are operating on it. Haath hilao, naam bolo, and we are taking out the tumor. And we know, okay, he is able to do that. That means we have not damaged this area. That's the purpose of awake craniotomy. But it requires a very cooperative patient to do it. Number one. Number two, and only basic brute functions can be assessed. You cannot assess the final function. A human brain has many functions for normal life. Abstract thinking, judgment, right? Decision making, right? Planning, execution, many things. We are only able to assess brute function, hand movement, speech, that's it. Then there is another thing known as, which we already use, is intraoperating nerve monitoring. When you touch a cortex, it can tell you the location downstairs with the electrode that yes, this is the area you have touched, right? But it does not tell you the executive function of that area. We don't know. We can know that this is the area responsible for something, which is showing down in the electrode recording. But we don't know the executive function. Those are the limitations of all the latest tools which we have been using for years. So now, I'm just telling about something. Brain mapping is an old term. But this is a latest technique which has come across the world, and probably, if Sachin is, we are the first hospital in India to incorporate that. That is the main thing. This is something known as connectomics. What is connectomics? So there is a definition of brain connectome. So brain connectome means connections, basically. Entire set of complex connections that make up human brain. Don't look at brain as a specific area for some function. No, it's a complex network. Each area is connected to other area. Connectome is a white matter between the cortex and subcortical structures. Connections act as wires to transfer information between functional areas. And connectomics is the big data approach to constructing and analyzing a computer-generated map of the brain, functional and structural connections. Now I'll come to this. What happened? Broadband model. We know that broadband area, we read in MBBS also, that Dr. Broadband had actually mapped the brain in 1909, categorizing the brain to 47 areas responsible for various activities. Somehow, mankind slept for 100 years. Science has evolved, neuroscience has evolved, but nobody did anything apart from that. 1909 brain mapping, after that a lull of 100 years, more than 100 years. So what was broadband model? The based on anatomical and cellular structure of brain surface, right? Model divided the human brain into around 47 parts or parcellations we say. It does not explain anything beyond very basic functions such as movement and speech. Just like word map cannot explain the complex interrelationship and the interaction between countries and cultures. We know this is Russia, this is Ukraine, but what is the relation between them? We don't know, right? So there was a very important project, actually behind the lines. President Obama funded that. It was funded in 2009. Project was commenced, 100 years exactly. And it was a 38.5 million project sponsored by NIH, National Institute of Health, Washington. So 1,000 plus subjects with 350 plus families were subjected to advanced MRI techniques. And they mapped their brain, again, with the evolution technologies, not those 1909. And they developed a new brain map, atlas defined brain areas based on how they were both functionally and structurally connected. So this atlas segments the brain based on cortical architecture, functional connectivity and topography. So they changed the entire thing. And there's an evolution which has happened somehow which was lull for 100 years. So they have actually categorized the brain into 7 major networks: sensory motor, visual, limbic, central executive or CEN, default mode DMN, salience and dorsal attention. So they have color coded it in a software. Those are known as parcellations, and there are finer parcellations to that also. So what are brain networks? Networks are nodes that are wired together and fired together. They serve as common purpose but mix parts to create higher cognitive function, and they lie in hierarchy. A higher function controls a lower center, higher center to lower center. How does it all work? So they are all connected. For the brain to function efficiently, all the networks appear to align around salience, DMN, salience, and central executive network. So execution based on the salience. Salience means the satiety of the salience of the brain, the organized brain, right, and internal mental state. Apart from the food functions. So this is just a Dr. Tulsi. I'll just be very brief. Okay, I won't go into tables, but these are very important tables for neuroscience.
Yeah, please.
So these are just to tell you. So there is a DMN network they have decided. They have actually seen or made the default mode network. This is active during rest and sleep. It is instrumental in cognition, regulation of emotion, abstract function. And if this is damaged, then it can lead to neuropsychiatric disorders such as inability to process social situations. Similarly, central executive network for task and decision making, and instrumental in working memory and executive function. But if it is disrupted, the major behavioral disorders such as depression and autism. Something like that. Salience is very important. It is constantly a conductor between C and DMN, and it is coordinating various networks, right? And if it is damaged, then you have patient can have chronic pain syndrome, schizophrenia, etc. So something like that. It is basically the networks which are responsible, and we know the starting and ending point, but somehow we have been missing the connecting points. That's what I'm trying to tell you. So there is a slide on this which actually maps. There is a MRI sequences with the pasted parcellation areas responsible for various functions. For example, mental attention network, these are the areas. Central executive networks, those are the areas. Salience networks, limbic, default mode network, and dorsal attention network. These are the areas which are already labeled. Now the beauty is every individual's brain is different, every pathology is different, and these areas and tracts can shift. That is the another important thing which has happened with this correctomics. Now the question is again, I told you eloquent brain. How can we avoid damaging eloquent brain? The question is every part of brain is eloquent. You can't label one portion to be eloquent, rest to be non-eloquent. No. So what we were doing earlier, lower order networks, sensory motor speech visual, period. We can achieve with that awakeniotomy or intraoperating nerve monitoring. We can do that. We have been doing that. But what about higher order networks? For example, salience, executive function, right? Social behavior, euphoria, interaction, depression, all those things, right? Anxiety. So they are all due to something being, working properly or not working properly. So higher order network was never focused upon. Now we are coming to that. So quick talk. It provides a personalized, patient-specific map of all brain networks, including DMNC and fat salience, and and sensory motor. And most important for surgeons, it corrects for tumors and edema. Every tumor has an edema. It grows, it pushes the tracts, right? The fibers which are actually connecting various areas. And then the tumor also induces edema to the surrounding structures, which further pushes them. So this software or this technology actually identifies what has tumor caused and what is the edema around tumor caused and shifted the important fibers to which place. So that is very important for us to understand in surgery. It's not a prefix atlas, it is patient specific. It easily transfers information into your intraoperative frameless histootechnic guidance system. Now neuro navigation. We have operated 10 cases with this till now. I think for last 3 months? 1 month, okay. We started this. And we have navigation system. It is easily incorporated with that. And it is user friendly, FDA approved, requires no more time than a normal MRI. And what do? So we take MRI pictures, we take a scan and we send it to Omni Cloud Access. In US, the facility which organizes and works on this software. It goes directly to them. They do the noise correction, they do the edema correction, they make the tracts, they correct it based on tumor and edema, they send it back to neurosurgery department. It is again fed into PACS and the navigation system, and then we use it during the surgery. So during surgery we know, while operating, this is the tumor, now here we have to enter, here are the fibers, these fibers are responsible for this thing, these fibers are responsible for this thing, these are shifted this much, so we can go from here. That's a very important help for a surgery. And it actually favors a very good outcome. So these are a few publications, sir. Just, it has been only 7 minutes.
About 25 minutes.
No, sir. So it is actually reducing the cognitive footprint of brain tumor surgery. These are the few publications which are telling about that. They have also done a study, the frontal ascending tract supplementary motor area syndrome. So based on connectomics, now I'll tell you the lower points. So there is fat preservation. Basically, fat is frontal ascending tract, which is important for supplementary motor area syndrome. So there we have done without this victome, and with victome, so see lower down there is a temporary SMA syndrome in 11 out of 23 patients. There it is only 2 out of 22 patients, and permanent is in 3 and there is 0. So there is a significant improvement in the surgical outcomes by application of victome. Now it's just a thing what this is on my computer in the hospital. The image directly comes. We know so these are corticospinal tract and motor parcellation of a person. We know this is the tumor you can see, and there are the fibers. We are far away from it. We know how to go about it. Then sensory motor parcellations. We know the sensations also and the motor aspect also. These are the real time things which patient is already having. It's not a previous based atlas. It is an actual thing. Then language parcellations. We know these areas are responsible for his language, not the language of Broca's areas or Wernicke's area. No, the fibers even in supplementary motor area which are responsible for movement of your larynx and tongue and everything. So that tells you this, right? And we have taken out the tumor. The patient is absolutely found fine without any deficit. So those are the advantages. I'll be very short, sir. The last thing is the conclusion. Now, it's a useful tool for good surgical outcome in brain tumors, number 1. That we agree after using it. Number 2, an evolution at how we look at the brain as complex network of circuits. It's not a patchy thing, assembled together. No. It's a very big computer with complex networks in between, right? And the other thing which is very important I have to mention here with the stroke and all those things, this victome is a template for any more feasible possibilities for management of various elements of brain. For example, Sachin will tell you better, we are using transcranial magnetic stimulation for stroke patients, where we do victome. We know that tracts which are actually to be stimulated by magnetic stimulation, and we see the results. So we identify the areas which are to be focused on rehabilitation and stimulation. Thank you, sir.
Very good.
Friends, finally, before we can have some question and answers, I'd like to ask Dr. Choudhary to give a little introduction regarding the stroke unit that they have at IBS Hospital, the state-of-the-art stroke unit. Dr. Choudhary.
Good evening, everyone. So we had a quick discussion about connectivity. So just to put it in layman language, so connectivity is the knowledge of the connections between the states. Like brain is like India, we know about the states, but not with the air connection and train connection. So whenever a city is not working, not the state is affected, but the country is affected. The personalized brain map is something which has led us to know about the networks in the brain that we never knew existed. And now the research is aimed at further probing. Research is aimed at further probing how we can use and modulate these tracks to get better recovery from drug disorders. The knowledge of electronics in brain tumor surgery makes it a designer brain tumor surgery where patient can be convinced about a better outcome than conventional methods. Now, last time we had a discussion about launching a stroke care program. IBS is centrally located in the heart of South Delhi on Ring Road. So, if you look at territory from Nizamuddin till Kalkaji till Saket, so we are the most central one. So we decided that we should have a dedicated stroke unit. Although we have one, it will be like more in practice now. Since our impetus is on creating awareness amongst the population, at-risk population, through the physicians and the practitioners in the area, through RWAs, through patient education portals, and through internet, social network. So the idea is to promote the awareness for how not to miss a symptom of stroke, identified early, because we know that, we just explained, early intervention can lead to complete recovery or to avoid disastrous complications. We already are equipped with the best in the class rehab, so it would have been pertinent that we start with prevention, early management, and then rehab afterwards. So we need to create awareness among people, general population about these symptoms fast. Face drooping, arm weakness, speech, and time to call emergency. And the impetus is that whatever population we reach out to, we explain the relevance of all these things so that they don't waste any time in reaching a hospital. This is the number that we want you to remember, 365 days a year. So this all will be separated to all of you and the general population. There will be a separate set of people managing the helpline 24/7 so that there is no hiccups when the patient is being referred to the hospital. We have created a team of, right from the ambulance network, to bring the patient to hospital. Since we are a smaller hospital as compared to the bigger hospitals other than IBS, so the time from door to CT scan to ICU is quite short. We have in-house MRI, CT and all the equipment required, intervention, all ICU care. So a stroke patient can be dead relatively faster. So we seek your cooperation and support in this noble cause where we tend to emerge as a leader in stroke care, in acute stroke care and chronic stroke care in this area. Thank you, sir.
Hello.
So, friends, what a wonderful talk we have had, and we just can't forget such lovable persons like Dr. Choudhary, Dr. Sanjay Choudhary, Dr. Raj, we met last time, and Dr. Vikas Gupta, not to forget Dr. Chauhan, all of us, including me. So, let's have a round of applause for all of us. Okay, so let's start with Dr. Sanjay Choudhary. Wonderful talk, sir. So evidence-based guidelines recommend to modify the modifiable risk factors for strokes, the carotid IMT, the plaque are preclinical surrogate markers, not to forget the macroalbuminuria as well, which is a marker for vascular endothelial dysfunction. Systemic vascular endothelial dysfunction. Sir, let's talk about that.
Yes, sir. As I have said, in fact, there is a genetic basis also, though it is not very crystal clear, but there are genes which are responsible for the carotid, intima, and media thickness. So those have been studied, but still the jury is still not out. There are some trials which have seen that they might be modified or they might be controlled, but definitely it is without any doubt that the intima, media thickness and the carotid plaques, especially the nature of the plaques, are very important when we advise for further intervention, especially like stenting or whether we need to go for endarterectomy. But one must understand that they have to be in the same region where the patient is symptomatic. For example, many times we see the right carotid is having a problem and the patient is symptomatic on the same side. That cannot be explained. So that means we have to be logical. There may be some other reason. So we must have to properly evaluate the patient, and when the clinical symptoms and the investigation they tally, then we have to go in for interventions. And vascular risk factors, as I have already said, they are multiple, but there is a complex interplay between the genes, the environmental factor and the acquired factors. And depending on extent of all strokes, that can be because of Ehlers-Danlos system or syndrome, or it can be because of sickle cell disease, or it can be because of CADASIL. There are single genic involvement. Apart from this, there are many genetic involvement. But on top of that, the environmental factors, they make it a change. And any of these, like albumin, they can also cause myoglobin. They can also cause an increased risk factor. But they always act to those 10 important modifiable factors which I have.
So, Dr. Choudhary, probably we'll have next time regarding the treatment of ischemic strokes. It's a vast subject, but as Dr. Podar would agree with me, alcohol, see, improves HDL and reduces platelet aggregation and lowers plasma fibrinogen levels at the prescribed doses. And if you exceed, probably the opposite effects are seen. Dr. Choudhary,
Yes.
tell us for the benefit of Dr. Podar and all of us.
Dr. Kumar knows his limits, so he is in the safe zone. So, as I said, it is a J-shaped curve, so a couple of drinks a day is fine. But if it is beyond that, then yes, a person is at a higher risk of having both ischemic as well as hemorrhagic stroke. Hemorrhagic stroke, it is more crystal clear connection. With ischemic stroke, still you have some sort of leverage. But again, as I said, no one factor is important. So there are maybe he has his genes in which he can go up to more drinks, but he will not have any problem at all. So it's a complex intervention. But as a whole, we must say, and we must warn our patients that we should not go beyond the limit on a regular basis.
So as Dr. Chauhan said, we should have the audience also participation, but before everyone else asks, let me ask, today is Alzheimer's Day, friends. And what's the theme today? Learn dementia, learn Alzheimer's.
Yes.
So this is the theme for 2022. And Dr. Choudhary, do we have any advancement in the treatment of Alzheimer's?
Yes, sir. Alzheimer's disease, as we all know.
I'm talking about aducanumab, which probably is the drug of choice today.
Yes, sir. They are mainly is for migraine prevention.
No, sir. Alzheimer's disease just recently, US FDA approved this drug. It targets the beta amyloid deposits in the brain,
Yes.
which causes this problem. So this is the drug to be given today. It's approved by the US FDA just recently, just about maybe about 9 months back.
Yes,
Dr.
but there
Choudhary.
was some controversy regarding it because the team which we communicated, then there was some controversies as to the FDA approval, but not too much of correctly done. So we are not very keen on it, and so the trial which has been done regarding this, there are some limitations. Approval has been maybe jumped upon. So we don't, as a person, suppose it comes to India, we do not recommend it. We need more proof, more evidence before we recommend it to Indian persons.
So, friends, let's talk a little about the SGLT2 inhibitor. It has neutral effects in strokes prevention, but GLP-1 agonists are the drugs to be given here. Just talk us through the GLP-1 agonists. They are neuroprotective.
They are
Just tell us about the GLP-1 agonists in the treatment of strokes, Parkinson's disease,
Yes.
as well. Please, sir.
Basically, trials are still underway with their stage 1 and stage 2 trials. Stage 3 trials are still new. Basically, they reveal, because it helps by preventing further intracellular damage through the lysosome. And so, but it is still theoretical. Stage 2 trials are only done. Stage 3 trials are being awaited, especially in Parkinson's disease. And in fact, there is a concept of prevention of these disorders. But point is, when the patient comes to us, usually patients are quite advanced. But still, if they help our patients, then we will become good.
So, friends, GLP-1 agonists, the Strokes Journal published an article just about 6 months back, and they said they indeed reduce the risk of strokes, Dr. Malkalra, in type 2 diabetes, and many guidelines now recommend the use these drugs to lower the risk of strokes. A recent study published in Lancet Neurology also talked about reduction in strokes with GLP-1 agonist. Not to forget the ADA in diabetes care who endorsed this in March 2022.
Can I just request everyone to keep decorum please for next 10 minutes? It is so disappointing to have this noise.
Please stop it.
We are making efforts to give you some knowledge. You are undoing everything. Don't make noise.
So finally, friends, Dr. Vikas Gupta gave a wonderful talk on personalized brain mapping. Friends, this is the one of its kind in the country. Nobody else has it. Dr. Vikas, Dr. Kandari, what do you say? Nobody has it. So, Dr. Vikas, would you say that this probably has, accurate, precise and safer, first of its kind, neuromodulation by targeting stimulation in epilepsy, in PD as well, in depression, drug-resistant depressions, and that's about. Tell us a little about the brain mapping, personalized brain mapping, the first of its kind in the country.
Okay, so basically I talked about the surgical aspect of it because I am operating on the patients using them. But at our center we know that there are various applications of this. As I told you briefly that there is a transcranial magnetic stimulation. So for TMS we need specific, we need to know the circuits where we have to target to actually receive the best response possible. And that's one thing, for that this is required. Personalized brain mapping actually is going to help you a lot in even magnetic stimulation or even cortical stimulation for that. Right?
So that.
So I'll just explain this in a bit.
Yes.
So what the brain map has given us the new dimension is that we know a few connections or tracks and networks which we were not aware of before. With that comes the implication that what do these tracks do and how we can modulate them for better recovery or prognostication in patient. So the salience network, the CE and DMF has been found that in psychiatric illness to start with autism or bipolar disorder OCD, if you do the interplay of both the networks DMN and CEM, you can achieve a state of semblance where there is a balance in the brain. So how do we modulate that circuit is by doing the transcranial magnetic stimulation. So patient undergoes a special scan, you get a QR code kind of a thing, you see the red dots on that, and when you point to that dot, it will direct you to a certain tract in the brain which is not seen otherwise in the MRI. Then you take the patient to operation theatre to use a navigation tool to mark the same location on the brain and that stimulate that with a magnetic stimulation. So much so that even stroke and conditions like intractable pain have been treated very well with this knowledge of PMS combined with electronics. So research is still going on, and we have already started stroke program with this. We started PMS for 2 patients on stroke. People have been using this for depression for so many years, FDA cleared for that, but the efficacy is only 40%. But when you use that along with electronics, the efficacy goes up to 87%.
Wonderful, sir. My last question to Dr. Choudhary would be about, the latest probably modality of probably the standard of care today in PD would be the focused ultrasound, which has just come and approved by US FDA just a few months back. So the focused ultrasound in the management of PD, the latest management of PD.
Yes, sir. To be more specific, sir, it is not any case of Parkinson's, rather tremors. Those patients who are mainly troubled by unilateral tremor, because focused ultrasound has to be done unilaterally. So only if the tremor is more marked on one side, you cannot target both the sides.
But now, Dr. Choudhary,
DBS is bilateral.
no. Probably now, the promising results are available today in bilateral focused ultrasound, and they are very promising.
Yes, sir. But tremors, but mainly for tremors. In fact, it can be very
Essential
focused.
tremors.
Essential tremors can also be used, but
Right.
when you say it's Parkinson's, usually it is unilateral. So whenever there is more tremor on one side, if there is associated rigidity, hypokinesia, bradykinesia, then it cannot be used. Only for tremors, it does not improve.
Please correct me if I am wrong.
Yes, sir.
So probably promising results now achieved by in bilateral focused ultrasound. See, these studies are very recent. So
Focused ultrasound means these are non-invasive. That's the best part.
Yeah.
So these are
But for advanced PD, and this probably is the
Only for the
modality
tremors.
of choice for advanced PD. This is the latest treatment for PD.
For tremors, yes, but not for advanced Parkinson's with rigidity and hypokinesia. Only tremors.
So he said not for non-motor functions, probably dopamine functions.
Yes.
So
Only
he said
for
that
tremors.
only for
I have prepared a
tremors.
slide on this.
What about
Permit
rigidity
me, I
and
have to show it to you.
yeah, okay, sir.
Just
Yeah,
for
Dr.
everyone.
All of us? Yeah, go ahead.
It's time to give chance to everyone else.
Go ahead, sir.
Just one question to everyone. Sir, is the stroke helpline already working?
Yes, sir, from today onwards.
From today onwards. Now, if I refer a case of stroke, sir, let's say thrombotic stroke,
Yeah.
what every patient, I have been their family doctor for 25 years, they always ask about the money. कि सर क्या खर्चा होगा अगर हम यहाँ पे जाएंगे तो हम उनको क्या खर्चा बताएं सर because you said you have in-house CT, you have in-house MRI, and all the modalities, maybe TPA, etc. So what kind of expenditure are we looking at?
So if we consider a ischemic stroke and patient reaching us within 3 or 4 hours of the onset symptoms, the main expense is going to be the antibiotics, the medicine, and based on the body weight, it's 50 milligram or 70 milligram. So that will cost equivalent to 1,000 per milligram. So 70 grams. So that is the main expense, and patient has to be in ICU for 1 day, and we repeat the CT scan next day. At onset, we do an MRI diffusion study, and the MRI will be made available to the patient even if some studies are ongoing because we are aware of the
Sir,
level of the patient.
पैसा कितना बताएं?
Sir, you can give an estimate for the first 3 days about 1 lakh rupees or 1 lakh.
सर टोटल पैकेज बताइए मैं उसको बोलूँ 7 दिन रह के आना पड़ेगा भाई
Sir, वो 7 दिन क्यों रहेगा? थ्रोम्बोलाइज कर किस ले रहे हैं?
नहीं मैं एक चीज बता रहा हूँ
Maximum.
3 days कितना पैसा सर
1.25 lakhs.
उतने में हो जाएगा
Body weight dependent है. The dose is
सर बॉडी वेट को छोड़ दीजिए सर मैं कह रहा हूँ 1.5 लाख बताइए सर 1.75 लाख बताइए सर कितना बता दें मरीज को ये बताओ
MRP, but the range may be 1.25 to 1.5.
उसको बोल दें 2 लाख के अंदर निपट जाएगा भाई
Yeah, if in case there is no handling transformation.
सर वो तो बात की बात है ना वो तो बात की बात है just a minute
In a uncommon case, 1.5 to 2 lakh or 3 to 5 years of stay.
ठीक है, thank you very much.
And not to ignore the TIAs.
So that is
ignore the TIAs that will give aspirin topical and go home and talk to me tomorrow. That should not be the practice.
So as Dr. Sanjay Choudhary said that in TIA actually the rate of recurrent stroke is much higher than the normal stroke. In 3 months it is 10%.
Yes.
So if I have a patient who had a TIA at 12 o'clock in the afternoon, comes to me at 7 o'clock in my OPD and now says, I am fine doctor, there is no problem, I should still motivate him to come to you.
Yes.
He should spend the night at the hospital.
He should spend the night at the hospital. That is the right. And he should be investigated.
Yes.
With everything, with every modality possible.
You don't get two lucky chances. Not one lucky chance, but go to the hospital and avoid the second stroke.
Right. Dr. Vikas, sir, you said about the occlusions in the carotid artery and the branches of.
शक्ल नहीं नजर आएगी। YouTube पे कुछ नहीं नजर आएगा।
Okay, ना मुझे YouTube का सब कुछ खास नहीं है।
YouTube पे डालना चाहिए।
We'll have it.
Right, right. Sir,
Brain mapping. I said about brain mapping.
I just wanted to ask you, in these occlusions, whether endarterectomy or stenting, which one is better?
Normally we say in a patient who had a TIA or a non-disabling stroke, within a span of say 2 weeks they should undergo either stenting or endarterectomy. Both are almost equal, but being less non-invasive than endarterectomy, and because the post-op morbidity is more, so I would prefer angioplasty. That is putting a stent in the endarterectomy. But obviously it depends on other associated comorbidities. Then only, but usually if you ask me one, I will go for aortic stenting rather than endarterectomy.
ठीक है sir. Over to you, sir.
So, Dr. Sanjay, you said in the causes of stroke, you said 20% are due to major atherosclerosis.
Yes,
Am I right?
20%, yes.
So, you among the preventable steps, you said all were to prevent atherosclerosis.
Atherosclerosis.
So, what about 80%?
So, in fact, the small vessel disease, these are large vessel disease. What you said is large vessel, like the carotids, the vertebrae, those major arteries. But there are very small arterioles within the brain. They account for the 25%. And apart from this, there is a cryptogenic stroke. That means we don't really know what is the reasons. We keep on investigating, and we usually presume that atrial fibrillation plays a major role in those cryptogenic strokes.
So, same factors will be
Because atherosclerosis is elsewhere.
Yes.
So same, basic concept is same. Only thing is that if it is a cardioembolic, then rather than anti-thrombotic, we should try to put the patient on to anticoagulants. Either initially in emergency phase, low-dose heparin, and then we put them over to oral anticoagulants like dabigatran or others.
Thank you. Just one question per person.
Sir, I'm really elated and to be part of the 800 CME by PFI. Congratulations to Dr. Chauhan and all his teamwork. Sir, Dr. Tulsi has taken one extra drink today. This is the extra day. Sir, मेरा सवाल यहाँ से शुरू होता है. I wanted, and there was a requirement of stroke ambulances. Do we still have it? Because I heard some number and all that. Do we have stroke ambulances per se?
Yeah, let him answer.
Yes.
So we have tied up with the major ambulance providers, 6 to be precise, so that we don't waste the time. If we have our own ambulance, so it will take time to reach the destination and then bring the patient back. In daily traffic, anything can be, 10 minutes can be done 1 hour in the traffic. So our plan is to educate, and once they are doing, there will be protocol set even for the vitals to be taken, so that we don't waste any time on the patient which is the hospital. So it's imperative to have more people taking to that command rather than our own hospital ambulances. We have 2 ambulances, but that can be used if it is nearby. If we
We
find
should be percolated to more into the society that we have stroke specific ambulances for the stroke. Sir, in one of very great CME, a great speaker, the cardiologist had said that CVD, cardiovascular disease, is as preventable as MTP. He didn't say pregnancy, but anyway. So is stroke also equal to that?
You every disease is important and we should give weightage and honor to every trained consultant and clinician in every field. So every disease is different, because I would not like to equate my stroke with MI. Everything is important. Every part of the body, if it is under insult, it has to be prevented, it has to be treated.
So we know the preventable causes,
yes.
and 80% try to prevent it as per your
Yes.
presentation also.
Yes.
Sir, the genetic study, I was very keen
Yes.
to know.
Yes.
Does it change our treatment?
Yes,
Once
sir.
we know the patient is having a stroke,
Yes.
and we somehow went into the genetic study also, will it make any change in our therapy?
Yes, sir. The genetic aspects cannot be corrected. We cannot change your genes, but you can change the way they behave by the additional modulation of the environmental and the risk factors. For example, give a specific example, like sickle cell disease. They say sickle cell disease, you have it, you don't. But they are amenable for plasma exchange, which has been shown to reduce the stroke incidence in future. So a person of sickle cell disease, we cannot say, oh, you can wish away the disease. They are going to have it for the rest of their lives. But whenever those who are very prone, we have to see to it that whenever there is a TIA, we can ask them to go for plasma exchange, which will reduce the chances of a stroke events.
Tulsi had mentioned today's Alzheimer's Day, International Alzheimer's Day. So we can't say Happy Alzheimer's Day. So there is something to implement it. So there were the recent treatment he was referring to. So anti-immunotherapy, sir. So it's thought to be autoimmune disease. It's only one hypothesis. It's not true one.
No.
So there was a vaccine also.
Yes.
In the development, I don't know whether it will go or not.
Yes.
So there are ways to prevent AD, and to meet friends is to prevent AD. Sir, my next question is
It
female.
removes, that is MAP,
One thing about
beta amyloid as well as the tau proteins.
Sir,
So this is the drug.
Something about
sir, vaccine also came.
about Alzheimer, even now recently, FDA approved a
Sir, nothing like meeting friends.
FDA approved is coming for deep brain stimulation,
Yeah.
the posterior commercial fornix for Alzheimer disease. It started already in US and we do plan to do it soon here also.
My feeling is meeting the friends is to prevent Alzheimer's disease. Sir, females more likely to have your stroke.
Yes.
That is just hovering over my mind.
Yes.
There are so many things. Females are protected from MI
Yes.
till menopause.
Yes.
So, are you talking till menopause or it is beyond that? Is it related to short coronary arteries? And about stress, if you say, वो तो लोग कहते हैं ये स्ट्रेस देते हैं, देते नहीं हैं. तो मुझे थोड़ा सा कंफ्यूजन है, थोड़ा सा क्लियर करो.
There are three,
And
four
estrogen
factors.
is preventive from
Yes.
he's talking about estrogen.
No,
Yeah.
there are three, four factors. Actually, during pregnancy and postpartum, we have more of postpartum strokes, more of venous thromboembolism in the peripartum period. So that is one risk factor. Second thing is those women who are taking OCPs. And third thing is
menopause.
So no, OCPs तो सर
So, post menopause तो बराबर हो जाते हैं.
नहीं, postmenopausal में क्या होता है? Then what happens is they live longer than
Right.
men. In general, there is no offense meant, but because they have a larger
वो
half-life.
हमारी यादों में भी रह जाते हैं सर. यादों में भी रह जाते
In
हैं.
fact, the main reason why our stroke incidence has increased is that we are living longer.
SP is a question.
At the 2 or 3 decades back, our lifespan was less. Now it is more. That's
सर
the
इससे
most.
पहले कि मेरे से वो फोर्स वो करें, लास्ट क्वेश्चन ये है कि FDA अप्रूवल, does it mean DGCA अप्रूवल also?
No.
हम इसमें देखते हैं FDA अप्रूवल, हमारी अप्रूवल है कि नहीं है?
नहीं,
Plus yoga is a brain mapping. I just want to know whether yoga matters or changes brain mapping.
In the brain
I will
mapping,
refer to him,
there,
sir.
Vikas Gupta.
That is for investigation.
What, sir?
Yoga
Ask your
can
question
change.
again.
Yeah. Can yoga affect your brain mapping?
No.
Okay.
But tracks are going to be the same.
We are still to learn, sir. Actually,
Dr. SP.
jury is still out. I would like to
Dr.
say.
SP.
गोवा नरेश की जय हो.
SP is a very important question. Dr. Johan, very important question.
Very simple question related to the brain stroke prevention.
Yes.
Sir, when I was in first floor of the MBS, there was a book, Applied Physiology. So my question today is related to the applied neurology. Sir, in our blood circulation, there are so many unwanted elements, bodies circulating everywhere, each and part of the body. They are creating problems everywhere, whether it be brain, heart, lower limb, upper limb, GRT, and kidney, everywhere. There is a technique to remove all these bodies, so-called total blood pheresis, prevalent in the European countries. So can we do here to remove all the body? They can prevent the brain stroke, cardiac stroke, and other stroke. What do you say?
As I told you, the stroke is not a unifactorial disease, it is a multifactorial disease. So many things are interplaying. Apart from the genes, the environmental and the acquired factors, like what we acquired. So, a person who is having alcohol every day will not have stroke every day. Will have stroke only after say 6 months when he has a URTI. So that's infection caused a trigger. So just because suppose there is reduction in the blood flow everywhere, but he will not have global weakness. He will have weakness only in the left hand or in the right hand, depending upon the reduction in the blood flow in that part of the brain. So it is not very easily said that, oh, you keep on apheresis and then that will take care. No. Because it is multifactorial. So our treatment also has to be multifactorial. We have to take care of all the risk factors, control them. Then only we can prevent it. In the individual therapy can have some advantage, can have some disadvantage. We have to weigh them. Only after controlled trials prove, then only we can use it.
Sir, thank you. I may say I am very thankful to IBS Hospital. I was in charge of COVID care in Saket Court Complex, and I had referred number of patients from Saket Court. There was a Judge Saab, Mr. Kamra, we unfortunately lost it, and Judge Saab, Amitabh Rawat, he was really saved by your team. And there are a number of judges who were saved, and really thankful to you people that you have worked and your team is so great, and I really appreciate that you people are working really very hard, and that was a very tough time when we are not able to get the beds.
Please ask the question.
Sir, my question is, sir, this is an opposition question. My question is, I'm a sexologist and I'm a sexologist. My question is, sir, there are a number of people who use sildenafil or adrenalin, and during using these drugs, they get strokes, and there are a number of deaths taking place in US, UK, and even in India. So my question is that, sir, if a patient is taking sildenafil or sildenafil, and if a patient is having a stroke, what should be the responsibility of the physician and what he should do, and what is the real-time help you people can do in that case?
So every stroke, whatever be the cause, whatever be the etiology, treatment is more or less same, because we have to improve the blood flow to the area of the part of the brain which is under inside. So treatment modality remains the same. So it may be a cardioembolic, but the therapy, like if they come to us within 4.5 hours, we can give them intravenous. If they come later, we can go for an intra-arterial or we can go for thrombectomy. And if not, if they come up say after 24 hours, 48 hours, then still we can help them with the stroke rehabilitation program. So we have something for everyone, for every case of stroke, whatever be the reason, whatever be the etiology. And we believe prevention is better than cure. So in those patients who have had minor TIA, they should try to avoid using these drugs if they have had some problems before. but not every person who takes them has a stroke.
Sir, I think we really need to wind it up. I would just give 2 minutes to Dr. J P S Tulsi sir to wind up this wonderful CME for all of us.
Thank you, thank you.
So friends, it's a house full.
Yeah.
As expected. What a wonderful talk we have had, wonderful deliberations as well, and we look forward to more talks from IBS.